Am I audible to you and also visible?
Yes, sir. Yes, you're audible and perfectly visible, sir.
Okay, fine. We'll wait for some time. Few students have joined, but if once the student population exceeds 10, we'll start the program.
Okay, no issue. Would you like to check your screen sharing, sir?
Okay. I think we will start the program. I think that should be all right.
Oh, okay then.
Okay, my dear students, we'll start the program. Today we will have some echo clippings, and anybody can answer the echo clippings. Describe. There will be a question on an echo clipping. It may be a diagnosis, or it may be a what is the investigation, whatever may be the question that you may have to answer, and that will give you a good insight into the echo examination. So this is something like an echo quiz. We'll show you about 30 echo clippings, and you should be able to make a correct diagnosis. At least you describe it and make a correct diagnosis. Okay, we'll start with the first one. Can you name this investigation? What is this test? What is the name of this test? It is a M-mode echo examination, and you name it, and what is the purpose for which this is being done. Not usually done because this is a difficult to image, difficult to get good pictures, and the information is not too much. But this is one of the investigations which are useful to assess the diastolic function of the left ventricle. And name the investigation, name the imaging technique, or not technique, image, name the imaging investigation. Anybody who would like to have a crack on it? Vensi, are you there? Vensi?
Yes, sir. Yes, sir.
Yeah, you must be getting well trained by in echocardiography. You are with Vijayaraghavan, it's not so.
Yes, sir.
So I think you should be able to identify this imaging modality.
It's a propagation velocity.
Very good. It's
Color
a,
mode.
yes, it's a color mode mitral inflow propagation velocity.
Yes.
Very good. What is it used for?
For the diastolic dysfunctions,
Yes.
if it 50 less than 50, that it's severe that is it's diastolic dysfunction, sir.
Yes, anything more than 50 centimeters per second velocity is normal. Less than 50 centimeters per second velocity indicates LV dysfunction. And this velocity will be measured 4 centimeters from the region of the mitral annulus.
Yes.
You measure the velocity 4 centimeters from the mitral annulus, and this is one of the methods to assess the LV diastolic function. And if the velocity, propagation velocity is less than 50 centimeters per second, that indicates there is a LV diastolic dysfunction. You know, the LV, when the LV dilates very easily and very quickly, the blood from the left atrium is sucked into the left ventricle. If the relaxation is slow, the relaxation is impaired, then the sucking effect is very much reduced, and consequently the mitral inflow velocity also comes down. And this is a method by which you can assess the LV diastolic dysfunction. Okay, right. So it is a color M mode mitral inflow propagation velocity. Okay, diagnosis.
So LA myxoma, sir.
LA myxoma, very good. Is it Bensi again?
Yes, sir.
You must be very good in echo. Why do you say it's an LA myxoma?
Sir, because there is a echogenic mass in the left atrium.
Okay.
And that which during the
during the
systole,
during systole you are imaging a mass in the left atrium, which is not there during diastole. So what is really happening during systole? What happens? Why did you diagnose that it is left atrial myxoma? Then see.
Yes.
during systole, what happens to the left atrial myxoma? It's a pedungulated mass. During diastole, what happens?
It's pushed into the cavity.
Oh, yeah. During diastole, it drops into the mitral annulus, and sometimes it may project partly into the left ventricle. But during systole, when the mitral valve is closed, it is pushed back into the left atrium, and when you image the left atrium, the mass can be picked up. So when you pick up a mass during systolic phase and no mass is picked up during diastolic phase in the left atrium, then always think of a possibility of left atrial myxoma. Very good, Bensi. You can see that here. See, left atrial myxoma falls into the mitral valve, and during systole it's pushed back into the left atrium. And then when you image the part of the left atrial myxoma is imaged, and that gives you a clue to the diagnosis of left atrial myxoma. Actually, left atrial myxoma is one of the earliest diagnosis made with the help of M-mode echocardiography. Of course, the first one was mitral stenosis, and then another diagnosis made was left atrial myxoma. And in left atrial myxoma, during systolic phase, when it is pushed back into the left atrium, the M-mode imaging also can pick up the image of the left atrial myxoma. And during diastole, the myxoma is pushed back into the mitral orifice or partly into the left ventricle, and no more imaging of the left atrial myxoma is possible. So whenever you see an image or a mass picked up in M-mode echocardiogram during systolic phase in the left atrium, then always think of the possibility of left atrial myxoma. Very good. Diagnosis. Others can also try. Bensi also can try. Anybody can try. This is an M-mode tracing. What is the diagnosis? Concentrate on the mitral leaflet, anterior mitral leaflet.
Fluttering of the mitral.
Yes, there is a fluttering of the anterior mitral leaflet. What does that indicate?
That regurgitation.
What regurgitation?
Aortic regurgitation.
Yes, it indicates severe aortic regurgitation. This is one of the mechanisms by means of which the Austin-Flynn murmur is generated. So there is a fluttering movement of the anterior mitral leaflet, which is suggestive of severe aortic regurgitation. Very good. Okay. What does this image show? Diagnosis. Anybody, what do you find here? There's something you are seeing here. You can see something here. Same thing is seen here also. What is it? And what is the diagnosis? What is this structure, this one? That should not be a problem. What is this? And there's something across that.
Is it interatrial septal thrombus, sir, or aneurysm?
Yeah, It is endarteral septum. What do you mean by endarteral septal thrombus? Thrombus. How can there be a thrombus on the endarteral septum? There's
Aneurysm.
no, it is not an aneurysm. It is a thrombus, I agree. Then what is the thrombus doing?
It's moving between both the atria, sir, both right and left.
What is it?
Through the PFO, sir.
Very good. It is a thrombus in transit through the PFO. This patient actually presented. This patient presented with severe pulmonary arterial hypertension and had a stroke. And the neurologist wanted to have a cardiology opinion. And when we examined the patient, she had we detected a thrombus in transit through the patent foramen vein. She patient was immediately anticoagulated, and within a week's time, everything disappeared, and she had a very good recovery. So this is a clot in transit through the patent foramen vein. Why do in this patient there was a the right atrial pressure was elevated because patient had tricuspid regurgitation and also had significant pulmonary arterial hypertension. Patient must have had recurrent episodes of pulmonary embolism. So that also resulted in right atrial pressure getting larger and stretching of the endarteral septum, and so the passage through the patent foramen vein was much more easy. So this is a case of clot transiting through the patent foramen vein. Clot migration through patent foramen vein. We're seeing something here.
Infective
Infective endocarditis, not exactly right. Infective endocarditis, is there a tumor which can simulate infective endocarditis?
Fibroelastoma, sir.
Fibroelastoma, papillary fibroelastoma. The difference between papillary fibroelastoma and infective endocarditis is that the papillary fibroelastoma will be seen in the downstream, while the infective endocarditis vegetations are seen in the upstream. For example, if there is a infective endocarditis vegetation related to mitral valve, it will be usually seen on the left atrial side of the mitral valve. While papillary fibroelastomas will be seen in the left ventricular side. Similarly, in the aortic position, the same thing applies. The infective endocarditis vegetations are seen on the LV side of the aortic valve, while the papillary fibroelastomas are seen on the aortic side of the aortic valve. It may simulate infective endocarditis vegetations, but if you are carefully looking at it, then you will be able to recognize that they are slightly different. What is the problem of what do you do for these patients? Treatment.
Surgery.
It is benign, nothing.
You can. What is the problem of papillary fibroelastoma?
Recurrence.
Systemic embolization.
Systemic embolization. Why do they have systemic embolization?
They have crypts in between, and
Yeah,
there
they have
is-
got crypts in the tumor mass. There are plenty of crypts in the tumor mass, and hence small clots may be formed, which may get dislodged and can give rise to systemic embolization. So that is the problem of papillary fibroelastoma. As long as there is no systemic embolization, you need not hurry for a resection. Otherwise, if there is an episode, then it is better to resect. These patients can be started on aspirin, and there is no definite indication for oral anticoagulation, but these patients can be started on antiplatelets. And if there is an embolic episode, then yes, there is an indication for removing the tumor mass. So it's a papillary fibroelastoma. Papillary fibroelastoma. Can you recognize this scientist? I'll give you a clue. He is the father of angioplasty.
Mason Sones.
Hmm? What did you say?
Mason Sones.
No, Mason is not the angioplasty man. What did he do? He also is very famous. What did he do? Why is he famous for? Mason Sones. The Sones Cathedral is. He is the man who did first coronary angiogram. Yeah, he was doing a cardiac catheterization of the aortic valve. I have been a patient with aortic stenosis, and accidentally the catheter went into the right coronary artery. He thought that it has actually got into the left ventricle. So he injected a dye into it, and immediately the coronary artery was pacified. At that time, it was thought that canalizing the coronary artery is extremely dangerous. At that time, Sones was as a resident, and his chief was sitting in his room, and he immediately ran to the cath lab, thinking that there will be ventricular fibrillation. But nothing happened to the patient. And that was the first coronary angiogram and the beginning of the story of coronary angiogram and subsequent all forms of treatment for coronary artery disease. So this is a man who is the father of angioplasty. He is, anybody who would like to make a guess? He is Charles Theodore Daughter. So what he did was that he, in a patient with common iliac artery stenosis with severe claudication pain, he repeatedly dilated the lesion using larger and larger catheters. So he used increasing size of the catheters, and with the help of the increasing in size of the catheters, he could dilate the stenosed iliac artery, and the flow was established, and patient symptom of intermittent claudication disappeared. So the first person who thought of the possibility of angioplasty is Charles Theodore Daughter. The coronary angioplasty was started with the help of a balloon catheter, and who is the person who did it is Grandsig. So, but the concept of angioplasty was introduced by Charles Theodore Daughter. Okay, diagnosis.
Rhabdomyoma.
What did you say?
Rhabdomyoma, sir.
No, it's not rhabdomyoma. Rhabdomyomas are not common projecting into left atria. Usually they are in the myocardium, LV myocardium, and mostly it occurs in children, and it may be seen in newborn. And what is the natural history of rhabdomyoma? What is the natural history of most of the rhabdomyomas, especially those who are seen in children, are usually steadily as the child grows, it disappears. So no specific treatment is required for most of the patients with rhabdomyoma, but if the patient is having dangerous ventricular arrhythmias, or if the patient is having an outflow obstruction, and these are the patients who are symptomatic, may require removal of the rhabdomyoma. But most of the patients with rhabdomyoma can be left alone. It reduces in size, and in a good majority of them, it may totally disappear. Usually seen in the ventricular myocardium. This is not the location. Here, it is actually projecting into the left atrium. Where is it arising from?
Interatrial septal.
Interatrial septum. Is it moving out, or is it being, do you think that it is tied to the interatrial septum, or is it a connection to interatrial septum?
It is free floating.
Yeah, it's free floating, but is it moving around, or is it, it seems that there is an attachment to the interatrial septum?
There is an attachment.
Yeah, there's an attachment. So, it is a pedungulated mass attached to the interatrial septum. What is the commonest mass, pedungulated mass, which is attached to interatrial septum?
Thrombus.
Thrombus will move around. Usually,
Okay.
thrombus either it will be completely adherent, or it can be completely adherent, or it may move around. That's known as ball valve thrombus. This is not moving around. So, what is the pedungulated tumor arising from the interatrial septum?
Myxoma.
Myxoma. Myxoma is the common pedungulated tumor which is arising from the interatrial septum. And here you can see it is pedungulated. It is attached to interatrial septum. And only thing is it's very small, and it is not the usual site for, it is usually attached to interatrial septum. Common site for interatrial septal attachment is to the region of the fossa ovalis. And this is a left atrial myxoma. Okay, now it's coming to slightly more difficult one. This patient has got 3 problems to be identified. One each in each image. Eh?
Patient has underwent mitral valve replacement.
Yes, prosthetic valve replacement using what prosthetic
Ball
valve?
and cage.
Caged
ball and
ball.
cage.
Okay, very good.
Okay. And sir, there is a RV dysfunction.
RV dysfunction. Why did you say that?
Dilatation of RA and RV is there, sir.
Yeah, there is some degree of, maybe there is some degree of RV dysfunction. RA and RV are dilated, no doubt about it. So there may be some degree of RV dysfunction, but there are no parameters for us to definitely diagnose RV dysfunction. I agree with you that looking at the moment, there is some degree of RV dysfunction. Yes. You are
And,
right.
Severe tricuspid regurgitation.
Severe tricuspid regurgitation. One more. Look at the tricuspid valve carefully. What do you find? When you look at the tricuspid valve,
Caudal.
is there a doming of the tricuspid valve?
Yes, yes.
Yes, sir.
Yes, there is a doming of the tricuspid valve. What does that mean?
Rheumatic etiology.
Yeah, rheumatic etiology. What is the morbid anatomy? The tricuspid valve is doming. What is the morbid anatomy? Tricuspid.
Thick
Stenosis.
calcific.
Eh? When there is doming of the tricuspid valve, it is diagnostic of tricuspid stenosis.
Stenosis.
Yes.
Ah,
So this
stenosis.
patient is having prosthetic valve, caged ball prosthetic valve, which seems to be functioning normally. Severe tricuspid regurgitation, organic tricuspid stenosis, and probable associated RV dysfunction. Very good. Go to the next one. Organic TS and TR mitral valve replacement. Okay, right. What is this? This is a post-operative case. I will give you a clue. It's a post-operative case. It is not being done nowadays.
Alferi?
By mitra clip. So this is surgical treatment which was being practiced some time ago,
Alferi stitch.
and now it is
Alferi.
replaced by mitra clip. Yes. What did you say?
Alferi stage, sir.
Alferi stitch. It is it's a case of Alferi stitch, where you can see that the two mitral leaflets are stitched together, and you can actually see two openings for the mitral valve. And in the short axis, you can see that there appears that there are two openings, one here and one here, and this is shown to reduce the mitral regurgitation. And this is now being replaced by the mitra clip, which also is practiced on the same principle, where stitching of two anterior and posterior mitral leaflets together can significantly bring down the mitral regurgitation. So this is a Alferi stitch, post-operative case. Okay. Diagnosis. Bensi, you should be able to diagnose this without any difficulty.
The LV endomyocardial fibrosis.
Is it LV endomyocardial fibrosis or something?
Calcified.
Calcified, yes, that is there. The LV apex is calcified. What else is there?
RVOT is dilated. So RV also.
Yes, you can see that.
Biventricular.
Yes, this biventricular endomyocardial fibrosis. This is a apical calcification, apical obliteration of the left ventricle, and here is the apical obliteration of the right ventricle. It also is there is fibrosis and obliteration of the right ventricle, and there is a dilatation of the RV outflow, and there is some degree of pericardial
Peripheral
Fusion.
effusion. So this is a case of biventricular endomyocardial fibrosis with calcification of the LV apex, obliteration of the RV apex, and RV outflow dilatation, and there's some degree of pericardial effusion. Biventricular endomyocardial fibrosis. Okay, diagnosis, full diagnosis. Anybody can try.
RSOV to RV.
RSOV to, is it to RV or to the
RA, sorry, sir, RA.
RA? RSOV to ruptured sinus valsalva to right atrium. Which sinus is ruptured?
Non-coronary.
Non-coronary, very good. It's a non-coronary sinus rupture into the right atrium. Very good. It is a ruptured sinus valsalva, non-coronary sinus rupture into the right atrium. What is the commonest chamber to which the sinus valsalva rupture occurs? Of the cardiac chambers, which
Right
is
ventricle.
R.
right ventricle. Most 2/3 of the rupture occurs into the right ventricle. Some cases can rupture into the right atrium also, less than 1/3. And uncommon sites of rupture are into the pulmonary artery, into the left atrium, and sometimes the sinus can tunnel through the interventricular septum and may rupture into the left ventricle. So it's a ruptured sinus valsalva, non-coronary sinus into the right atrium. Diagnosis.
Bicuspid aortic.
All right, maybe bicuspid aortic valve. What else?
Aortic regurgitation.
Aortic regurgitation. What else?
Aortic dissection.
Aortic dissection. Very good. So this patient is having aortic dissection. You can see the flap, probably by a bicuspid aortic valve and aortic regurgitation. Very good. Excellent. So aortic dissection, aortic regurgitation, and most likely bicuspid aortic valve. So these patients can have aortopathy, and that is they may present with severe aneurysmal dilatation of the ascending aorta, and they can also have aortic dissection. Can you recognize this gentleman? He's a scientist. You may find it difficult. He's the man who popularized or did all the work related to cardiac catheterization. You know, first cardiac catheterization was done by Flossman on himself, but he did not pursue it. But the cardiac catheterization was developed into an art and a scientific investigation by a French physicist and physician, André Frederic Cournant. There's a catheter in the name of Cournant, which is an end-hole catheter, and which is used for mostly in pulmonary arterial wedge measurements. So this is André Frederic Cournant, who is a French physician and physiologist who popularized the cardiac catheterization in the diagnosis and management of various cardiac conditions. Diagnosis. This is a suprasternal notch view. Look at the abnormality and diagnose the condition. What is it that you are seeing here?
Innominate.
Eh? What is it? Is it an arterial flow or a venous flow?
Arterial.
What did you say it's arterial? What is the major difference between arterial flow and the venous flow?
Pulsatile continuous.
Yes, venous flow is
Continuous.
continuous, while arterial flow is mostly phasic. Is it a phasic or a continuous flow?
Continuous.
Continuous flow.
Continuous flow.
What is the direction of the flow? Is it if it is a suprasternal notch view, is the direction of the flow upwards or downwards?
Upwards.
Upwards. So if you are seeing a continuous flow upwards by the side of the descending thoracic aorta, what is the condition that you should suspect?
PDA.
Which one?
PDA, sir.
PDA, no, not PDA. PDA is that's not the location of the PDA. It is going up more towards the upper part of the neck.
LSVC.
Not the upper part of the neck, towards the it goes beyond the arch of aorta even. What is the abnormal way which can happen, which can occur there with
Left
a
SVC.
left SVC will be coming from here. When more often, many times the left SVC
Vertical vein, sir. Innominate vein.
Innominate.
innominate vein also comes here like this, but there's another vein going in this direction which may join the innominate vein. What is the name of the vein?
Azygous.
not azygos. Azygos actually, where does it join? It joins the
IVC.
superior vena cava.
SVC.
Here this is by the side of the descending thoracic aorta. When you find this is a continuous flow of this nature, you should always suspect the possibility of vertical vein. And vertical vein occurs in
PAPVC.
PPVC. So whenever you see a continuous flow, venous flow, where the blood is flowing towards the upwards by the side of the descending thoracic aorta, you should always suspect the possibility of PAPVC. This is a vertical vein draining into the left innominate vein and subsequently draining through the SVC into the heart. So this is a supracardiac variety of total anomalous pulmonary venous drainage. And what you are seeing here is the vertical vein. And you can see the venous flow and is draining through the vertical vein into the innominate vein and into the superior vena cava and back into the heart. Okay. What do you find there?
Myxoma,
Myxoma. Where is the myxoma?
left atrial.
Left atrium. Why did you say it's a left atrial myxoma? It is not moving.
Okay, sir. Right atrial.
Is it inside the heart or outside the heart?
Pericardial tumor compressing the
Yeah.
correct chamber.
Yeah, it is a pericardial mass compressing the. It's a pericardial
Atrium.
mass compressing the heart.
Atrium.
You can see that this is the mass which is compressing the heart. So it's a pericardial mass, and you can see areas of
Liquefaction.
circulation, fragmentation, liquefaction. All these suggest what?
Necrotic tumor mass.
Necrotic tumor mass. So it indicates malignant tumor of the
Pericardium.
pericardium. And what is the commonest tumor of the pericardium?
Mesothelioma.
Mesothelioma is the commonest, followed by fibroma. So this was actually a fibrosarcoma. Mesothelioma is the commonest, followed by fibrosarcoma. Okay. Diagnosis. This is slightly more difficult unless you are used to see pediatric cases. There may be difficulty in making the diagnosis. What is the diagnosis? You look at the cardiac chambers, size of the cardiac chambers. Yes, ASD. There's an ASD.
PDA.
PDA most likely is there. Why did there's a PDA?
Suprasternal vein.
In suprasternal view.
We can see a regurgitation. A turbulence is seen.
Not turbulence. What is the abnormality that you see in the suprasternal notch view?
Diastolic reversal.
Coarctation.
Not coarctation. What is the abnormality that you are recognizing in this suprasternal notch view? And in the descending thoracic aorta, what is the direction? What is the direction of blood flow?
Upward.
That is flowing downwards or upwards?
Upwards.
Upwards. Upwards.
Yeah, upward, it is flowing upwards. What is the abnormality there? Normally, what
Right
is the
side is down.
direction of flow in the descending thoracic aorta is downwards. Here it is upward.
Right side of the
Hmm?
right aortic arch.
What did you say? The blood is flowing from down. eh?
Diastolic reversal.
Yeah, there's a diastolic reversal of flow. Not because, need not be always aortic regurgitation. You look at the whole morbid anatomy and then come to the conclusion. What is this?
Right side of aortic arch, sir.
Right side aortic arch? The right side aortic arch, you should be able to see the aortic valve. You can see the normal pattern of the aortic arch.
Yes.
What is this? First image. What are you seeing here? This one. What do you see here?
Dissection.
Hmm? Of course, this is your diagnosis that there is an ASD,
ASD, PDA,
there's a PDA, and the flow is reversed here. What is this vessel? Branching.
one of the branches narrow.
This is a branching pulmonary artery, huge one. And look at the size of the aorta here. Aorta is very, very small compared to pulmonary artery. So what is happening to the aorta? Aorta is,
Coarctation.
don't go for coarctation. Ascending aorta coarctation can be even large. This is the left ventricle, and what is the size of the left ventricle? Here you can see the left ventricle is really small.
Transposition. TGA.
Why did you say transposition? Because the pulmonary artery is anterior and the aorta is posterior. Why did you say that it is transposition? What will be the anterior vessel in transposition? Is it the aorta or anterior or the pulmonary artery is anterior?
Aorta is anterior.
Aorta is anterior. So here the pulmonary artery is anterior, pulmonary artery is significantly dilated, aorta is small. So what is the condition that you should suspect?
Hypoplastic left heart.
Eh?
Hypoplastic left heart.
Yes, sir. It is hypoplastic left heart syndrome. Very small ascending aorta. You can see the mitral valve is practically atretic. You can see a small VSD here. And there is an ASD. There is pulmonary artery which is dilated and large. And you can see that the reversal of the flow in the descending thoracic aorta. This is because the blood coming from the PDA is flowing from the descending thoracic aorta up into the ascending and up into the arch and to the ascending thoracic aorta. So this is a case of hypoplastic left heart syndrome with atretic mitral valve, small atretic aorta, atretic left ventricle, ASD, small VSD, and patent ductus arteriosus. All these are there. So this is a complex and prognostically very bad heart lesion, congenital heart disease, hypoplastic left heart syndrome. Hypoplastic left heart syndrome, mitral aortic valve atresia, ASD, PDA. This you might have seen, and there should not be any difficulty for you to diagnose.
Contrast echo.
Yes, that is there.
Deroofing of a coronary sinus.
Why did you say deroofing of the coronary sinus? This is the coronary sinus.
Dilated coronary sinus.
Coronary sinus is definitely dilated. But why did you say that there is deroofing? Reason?
The color,
What is the contrast tell you? Where is the contrast injected and what is the purpose of doing the contrast? Suppose. Where is the contrast injected?
Left basically.
Yes, it is injected in the left upper arm, upper limb. Why it is injected in left upper limb?
TCC.
What is the structure? Which is at the junction of the just behind the mitral annulus. What is the structure?
To rule out
Coronary
LSVC, sir.
Yeah, just rule out LSVCs because you are finding a dilated
coronary sinus.
coronary sinus. So one of the reasons for what are the reasons in which coronary sinus can be dilated in the echo examination? One is the LSVC
LSVC.
into the coronary sinus. Two,
PAPVC
By
is
star
draining
of
into
the-
coronary.
yes,
Sinus.
PAPVC can drain into coronary sinus. Very good. Three,
Ruptured sinus of Valsalva in coronary.
reaching the coronary sinus is very, very unlikely. Any other condition? In a patient with right heart failure, what can happen to coronary sinus?
Dilated
Dilated. Why it gets dilated?
due to coronary Turgor effect.
Okay, no, you may not use the word coronary Turgor effect. You can say
Okay.
that right atrial pressure goes up in a patient with right heart failure. Patient sometimes can have tricuspid regurgitation, and that can also have effect on the right atrial pressure and also on the coronary sinus. When the right atrial pressure goes up, the pressure in the coronary sinus increases, the back pressure increases, that will result in dilatation of the coronary sinus. So in patients with the right heart failure, the coronary sinus can be dilated. Here, but a contrast injection has been done into the left upper limb, and what is the conclusion? Anybody? What is the conclusion? Is it a coronary sinus draining? Is it left SVC draining into coronary sinus? The injection has been done into the left upper limb. When injection is done in the left upper limb, what is the pattern of pacification of the coronary sinus and the right atrium in a patient with left SVC draining into coronary sinus? What will happen?
It will go through the left SVC to the
Coronary
coronary sinus,
Go
then
to the
enter
LSVC, then it reaches the coronary sinus, then only enters the
Body.
right
right
chambers.
ventricle or into the right atrium and into the right ventricle. So here it should go to the coronary sinus, through the coronary sinus into the into the right atrium, and then that's the way it courses. So when you are injecting a contrast into the left upper limb, the contrast should reach the left SVC, left IVC, left innominate vein, then it should reach the coronary sinus, and then it should only reach the right atrium. Here what you are seeing is that the contrast first reaches the right atrium and then it regurgitates into the coronary sinus. So this is not a ruptured, this is not a left SVC draining into the coronary sinus. What else it could be? It seems that here it is a recording is taken, it is a continuous flow. When there is a continuous flow, what should you suspect? Continuous flow occurs because of a communication between two chambers. One is having a continuously higher pressure compared to the other vessel, both in systole as well as in diastole. So what could be the condition that you can suspect where there is a continuous flow into the coronary sinus from some of the structures?
Fistula, sir. Coronary artery to
Very good. It's a fistula from a coronary artery to the coronary
coronary sinus.
coronary sinus fistula. You can see the significantly dilated coronary sinus. You can see the contrast getting first into the right atrium and the right ventricle. And you can see there is a continuous flow here, which is also recorded here, indicating that there was a high pressure flow coming into the coronary sinus. This was a case of coronary artery, coronary sinus fistula.
Sir, can coronary sinus ASD cause a dilated CS, sir?
Which one? Coronary?
Coronary sinus ASD, sir.
Coronary sinus
Can
ASD,
it cause a...
in a coronary sinus ASD, the blood is flowing from left atrium to right atrium. So, for the coronary sinus to dilate, what should happen? Coronary sinus to develop, the patient should develop right heart failure with elevation of the right atrial pressure. As long as the right atrial pressure remains normal, the coronary sinus will not be dilated. It will be dilated if the another situation where the coronary sinus can be dilated is sometimes if the patient is having tricuspid regurgitation and the jet is directed towards the ostium of the coronary sinus, then the coronary sinus can be sometimes dilated, where the jet is directed directly towards the ostium or the coronary sinus.
Okay, thank you.
Okay, this is a post-operative case. Can anybody diagnose? Nowadays, this is not being done. This is an old collection.
Switch operation.
Yeah, switch operation. What switch operation? Very good.
Atrial switch.
Atrial switch, yes. Either it could be Mustard procedure or it's a sending procedure. Why it has become unpopular? Why
because of the long-term complications.
Yes, what are the long-term complications? Can you mention 2-3 long-term complications of switch procedure?
Atrial arrhythmias.
Atrial arrhythmias, very good.
RV failure.
Yes, RV failure because of what? RV failure due to what? What is the reason? What is the mechanism? In such procedure, RV is exposed to what pressure?
High pressure.
High pressure. It is exposed to systemic pressure. And the RV is not structurally prepared to face systemic pressure for a long period. So over a period of time, when the patient is exposed to, when the RV is exposed to systemic pressure, it gradually fails. So many of these patients with the switch surgery, they started developing cardiac decompensation around the age of second decade. And the surgery became very unpopular. And as mentioned, atrial arrhythmias are quite frequent and very often notorious. It gives a lot of problems to the patient. Rarely during surgical procedure or during redirecting the blood flow, if by accident, if the opening of the pulmonary veins are damaged, that can result in pulmonary edema because of the pulmonary congestion. So because of this number of complications, and the benefit is not very good, the atrial switch surgery, which is either sending procedure or Mustard procedure, is not being carried out nowadays, and it is replaced by the arterial switch surgery. What is the problem of arterial switch surgery?
LV regression.
LV?
Hot block,
Hello.
KV block.
Not AV blocks are not common because you are not doing anything, but you are just switching the great vessels. That's all. Unless there is an VSD, there is no need to open the heart. If the innervator septum is intact, intraventricular septum is intact, the child is deeply cynosed and is having transversion of great arteries, the child can be operated. And the artery, the main arteries, the pulmonary artery and the aorta can be interchanged. But there are two problems in the switch surgery. One is that when you reimplant the one second. Hello. നാളെ ഒരു ഒത്തിരി നേരത്തെ പോണം. ഇന്ന് എന്നോട് പറഞ്ഞ വിപിൻ വരുമെന്നുള്ള. വിപിൻ വരുന്നില്ലേ? നേരത്തെ പോണം. അപ്പൊ ഒരു 8 മണിക്ക് ഇറങ്ങാന്നാ വിചാരിച്ചത്. അപ്പൊ അതിനനുസരിച്ച് വന്നു. 8 മണിക്ക്. ശരി ശരി. So the reimplanting of the coronary artery should be done carefully. Otherwise, these patients can develop coronary ostial narrowing. That's one problem. Second is that the pulmonary artery, which was previously attached to the left ventricle, which has been switched to the right ventricle, but the pulmonary valve remains with the left ventricle. So since the left ventricle is facing the systemic pressure, the pulmonary valve also is facing the systemic pressure. The pulmonary valve is structurally not prepared to face the systemic pressure. So these patients can develop pulmonary regurgitation, which actually is aortic regurgitation. So that's one complication that can happen with arterial switch. One, these patients sometimes, unless the reimplantation of the coronary artery is not properly done, that can result in coronary damage and coronary stenosis. And second, the pulmonary valve, which actually supports the systemic pressure, can develop in regurgitation, and the patient can present with aortic regurgitation. But this is a very successful surgery. If the patient is not having any VSD or only having a small ASD associated, if the surgery is carried out, the person can lead a perfectly normal life because the most of the anomalies are immediately corrected. The left ventricle is pumping the blood into the aorta and receives the blood from the left atrium, which is receiving the oxygenated blood. Everything is set right. Only problem is that the pulmonary valve, which is facing the systemic pressure, may develop aortic pulmonary regurgitation, which is aortic regurgitation over a period of time. So it's a very correct diagnosis. This is a switch surgery, arterial switch. This was a sending procedure. Okay. Diagnosis.
Supramitral drain.
Beg your pardon? Beg your pardon, you are right.
Supramitral aneurysm.
Your voice is broken.
Supramitral aneurysm.
Yeah, submitral aneurysm. You are right. It is submitral aneurysm with mitral regurgitation. What is submitral aneurysm? And in which group of people it is most frequently seen? What is submitral aneurysm? Submitral aneurysm is something like a pseudo aneurysm developing into the posterior aspect of the atrium. and it is secondary to a congenital weakening of the posterior part of the mitral annulus. The mitral annulus may be weak in its posterior part, and that region gives way and develops as an aneurysm into the posterior aspect of the left atrium. It is known as submitral aneurysm. It's most frequently seen in the African population. In addition to a congenital defect of the posterior part of the mitral annulus, there can be other causes like tuberculosis infection of the same region. Sometimes this has been described with ischemic heart disease, myocardial infarction, posterior and lateral myocardial infarction. So it has also been described in collagen disorders. So this acquired submitral aneurysm is also possible, but the most important reason of submitral aneurysm is congenital, where there is a weakening of the posterior part of the mitral annulus, and there can be aneurysm formation in the posterior aspect of the left atrium. So this is a submitral aneurysm, and it, actually when there is an aneurysm, it distorts the mitral valve and is almost always associated with mitral regurgitation. This is a submitral aneurysm with mitral regurgitation, and mainly it is thought to be due to a congenital weakening of the posterior part of the mitral annulus, and usually it is most frequently seen in the African population, and it can happen as an acquired one, especially associated with tuberculosis infection, posterior myocardial infarction, also can have this type of an aneurysm. Identify these two gentlemen, at least one of them. Who is this gentleman? He is the father of echocardiography.
Feigenbaum, sir.
Feigenbaum, not Feigenbaum. Feigenbaum has done lot of work and written good book on echocardiography, but the person who for the first time introduced echocardiography was Elder, and the person sitting next to him is his engineer who actually with the directions from Elder developed the first echo machine. So it is Elder, the doctor who thought of the possibility of ultrasound examination of the heart, echocardiogram, and his engineer Carl Hertz, who actually prepared or manufactured an echocardiograph so that Elder could use it. So this is Elder and Hertz. They are the two people who pioneered the echocardiograph. This is a difficult one. There are multiple lesions. Try to analyze and come to a diagnosis. It's a difficult one. What do you find there?
Tricuspid atresia.
Not tricuspid atresia. This is the tricuspid valve. See, you are seeing here, this is the tricuspid valve or this is the tricuspid valve?
AV canal defect.
AV canal,
Single,
right? You
single
can see,
ventricle with
you got the intravenous septum, you can see everything.
single ventricle.
Single ventricle, very good. One diagnosis, single ventricle, excellent. What else? Very good diagnosis, very good. Concentrate here. This is the parasternal long axis view. What do you find here?
Mitral valve.
Yes, is it mitral valve or something different? Still something is here and the valve is opening. What is it? Is that the mitral valve opening normally?
No.
Almost normal. There's some doming, but mostly normal. So, but the mitral orifice is not seen.
Parachute mitral valve.
Or triatriatum.
No, it's not triatriatum. Triatriatum usually it will be seen because the triatriatum, it has got two chambers. One, the upper one to which the pulmonary veins drain, and the lower one to which the left atrial appendage drain. Here, on top of the opening of the mitral valve, you see a membrane here. This is a supramitral membrane. So this is a supramitral membrane. Single ventricle.
Mitral atresia.
You cannot use the word mitral atresia because there is supramitral membrane. The blood is flowing through that narrow orifice, and the mitral valve is normal. It's opening and closing normally. And what do you find here? There is some evidence of stenosis of the supramitral membrane. And what are you hearing? What are you seeing here? There's aortic
Regurgitation.
regurgitation. So this is a case of one supramitral membrane, normally functioning mitral valve, mitral stenosis, definitely, mitral regurgitation. That will be the full diagnosis. So this is a case of supramitral membrane with significant stenosis of supramitral membrane, mitral regurgitation, aortic regurgitation, and single ventricle. It's a complex congenital anomaly. Okay, we'll go to the next one. What is this imaging? Is it a transthoracic imaging or a transesophageal imaging?
Transesophageal.
Transesophageal. And what do you find there?
LA appendage clot.
Very good. There's a large LA appendage clot. The patient is having a large left LA appendage clot. You can see it here. This is the clot, big, huge, the LA appendage clot. Diagnosis.
Restrictive cardiomyopathy.
Yes, restrictive cardiomyopathy. Can you name it?
Amyloidosis.
Amyloidosis. Why did you diagnose amyloidosis?
Speckling of the myocardium, interventricular septum.
Just there's hypertrophy or thickening of the interventricular septum. Even the free wall, RV, LV, everything is thickened, and there's some speckled appearance. And on top of that, even the endoatrial septum is thickened. There's no other condition where there can be endoatrial septal thickening. Or if the endoatrial septum also is increased in size, you can confidently make the diagnosis of amyloidosis. And as you rightly said, it is a restrictive cardiomyopathy with significant elevation of the LV filling pressures. You have to investigate and find out what is the type of amyloidosis, and depending on that, you have to resort to the correct treatment. Otherwise, these patients have got a very bad prognosis. Okay, what is this? This also is a congenital heart disease, multiple lesions.
IAS aneurysm is
Very good. In the interest of the aneurysm, excellent. Yes, what else?
PDA, sir.
PDA, very good, excellent. There's a PDA, very good. What is your opinion about the right heart structures? Are we normally developed or hypoplastic?
Hypoplastic.
hypoplastic.
Are we significantly hypoplastic? What about the tricuspid valve?
It's not opening.
It's not opening. It seems that there is a opening, but the leaflets are not opening effectively.
Tricuspid stenosis.
Yeah, so the patient is having at least tricuspid dysplasia with tricuspid stenosis. So what is your full diagnosis? The patient is having intrathecal aneurysm. What else? Patent access arteriosus. Hypoplastic left heart syndrome with hypoplastic or significantly stenosed tricuspid valve. So he has got multiple lesions. Patient is having intrathecal aneurysm. Patient is having PDA. Patient is having hypoplastic right heart. Even the the RV chamber is very small. It is very rudimentary. It seems that there is an opening in the tricuspid valve, which is very significantly hypoplastic, and the opening is the very small opening. You can see a PDA, and you can also detect continuous murmur at the location of the PDA. So this is another congenital heart disease where there is hypoplastic right heart syndrome, while the other patient had hypoplastic left heart syndrome. Many of these patients with intrathecal aneurysm will have an ASD associated with that. But there is a good point that most of these ASDs, more than 50% of these ASDs at the site of the intrathecal aneurysm spontaneously close. So that is a one plus point. But more than 50% of patients with intrathecal aneurysm and an ASD can have a spontaneous closure of the ASD. Diagnosis. What is this? Bullseye tracing?
Apical sparing, sir. Amyloidosis.
Amyloidosis. Very good. You can see that apex is spared and rest of the regions are involved. And this is described as chorion.
Top.
And this is suggestive of amyloidosis. This is a case of amyloidosis where you can see near normal strain here, but rest of the areas are significantly involved. So this is a case of amyloidosis. Very good. Diagnosis. Identify what is the tracing that you are getting, and then make the diagnosis.
Pulmonary valve Doppler.
Yes, very good. It's a pulmonary valve Doppler. Excellent. What do you find there? Very good. You are doing very well. Pulmonary valve Doppler.
That slope is reduced, so this
Yeah.
is stenosis.
Not reduce. What do you find here? When there is an A wave, you must be able to see at the time of the P wave, you should be able to see a wave. A normal pulmonary valve tracing. When the A waves are not seen, then what is the diagnosis that you make?
Atrial fibrillation.
Okay, atrial fibrillation can occur. It's associated with then atrial fibrillation. There is you can make a diagnosis with that. Of course, the diagnosis is here also. So this is a pulmonary valve tracing with absent A wave. Absent A wave can be due to atrial fibrillation, or it can happen in patients with severe pulmonary arterial hypertension also. But here it seems that the patient is in atrial fibrillation. I agree with you. It's irregular, and it seems that the patient is in atrial fibrillation. Okay, right. Pulmonary venous flow. How does pulmonary venous flow help you in diagnosing cardiac conditions? Pulmonary venous flow.
Severe mitral regurgitation, diastolic flow reversion.
Constrictive pericarditis.
Reversal?
Constrictive pericarditis.
No. Normally, what are the waves seen in patients with pulmonary venous flow?
SDAR.
SDIR, yes. And well, between S and D, which wave is more prominent?
Is D.
Which wave is prominent? S wave or R wave? Oh, sorry, D wave.
D wave.
D wave is more prominent. No, S wave is more prominent. Normally, S wave is very prominent, and D wave is much less prominent than the S wave. And this is followed by an air reversal. That is AR wave. But in certain conditions, what can happen is that the S wave becomes smaller and smaller, and may even become smaller than the D wave. And the AR, this air reversal, can become much more prominent. And what is the condition where you can get this pathology?
Mitral regurgitation.
It need not be always mitral regurgitation. Why should there be a reversal in mitral regurgitation? More prominent air reversal, what does that mean? That the left atrium is not able to drain its contents to the left ventricle. And because of the resistance to filling of the left ventricle, some of the blood is regurgitated into the pulmonary veins. That is why there is a prominent right atrial, air reversal. So what does that mean? The left atrium is not able to empty its contents into the left ventricle. Instead, it regurgitates into the pulmonary vein. And what is the pathology or morbid anatomy which can result in this type of a flow pattern?
Diastolic dysfunction, sir. Waist.
In patients with significant diastolic dysfunction, gradually the S wave size becomes less and less. There will be prominent air reversal. What is the level at which, how can you diagnose significant left atrial LV diastolic dysfunction by looking at the AR wave, air reversal? What are the things that you look at? None of you? By taking the duration of the air reversal, does it help? You will take the duration of the air reversal and take the duration of the A wave in the transmitral flow. And from air reversal, reduce the mitral A wave flow duration. And if the air reversal is more than 30 milliseconds, it indicates the LV dysfunction, and most likely the left atrial pressure is the LV end diastolic pressure is equal to or more than 15 millimeters of mercury. So one criteria that you look at is the duration of the air reversal in relation to the left atrial, the mitral flow of the mitral flow, A wave of the mitral flow. Here, if you look at the A wave of the pulmonary venous flow, it is 177 milliseconds. And if you look at here, the duration of the mitral A wave, it is 118 milliseconds. So 177 minus 118 is around 60 milliseconds. Anything more than 30 milliseconds is abnormal. So air reversal of the duration of the air reversal more than 30 milliseconds of the mitral A wave, it is suggestive of LV dysfunction. Second thing that you look at is the velocity of the air reversal. Of course, you can always look at the relationship between the S wave and the D wave. Normally, S wave is bigger than the D wave. In a patient with a diastolic dysfunction, gradually the height of the S wave comes down and the D wave becomes more and more prominent. If you look at the velocity of the air reversal, any velocity more than 35 centimeters per second indicates that the patient is having significant LV dysfunction, diastolic dysfunction. So in a patient with a diastolic dysfunction, the abnormalities that you find are one, the normally S wave is much more tall, much more prominent than the D wave. Here gradually the S wave becomes less and less prominent and may even become smaller than the D wave. Two, if you look at the air reversal, you take at the duration of the air reversal and the duration of the transmitral air wave is deducted from this, and if the resultant value is more than 30 milliseconds, that indicates severe LV diastolic dysfunction. Next thing that you can look at is the velocity of the air reversal. If the velocity of air reversal is equal to or more than 35 centimeters per second, that also indicate that the patient is having significant LV diastolic dysfunction. The prominent S wave and the prominent D wave usually the D wave becoming more prominent than S wave is a diastolic phenomenon, and usually that is associated with mean elevation of the diastolic pressure. But at the same time, the abnormalities that I have described about the air reversal, that's the duration as well as velocity, usually is an end diastolic event, and hence when the end diastolic pressure is elevated, these abnormalities can be easily picked up. So when you look at the pulmonary venous flow, by looking at the pulmonary venous flow, you can draw two conclusions. One, the mean elevation of the pulmonary venous pressure, and two, the end diastolic pressure elevation, as can happen in patients with air reversal duration more than 30 milliseconds and velocity more than 35 centimeters per second. So this is the air reversal that is recognized by timing it with the P wave, and this is the diastolic wave, this is the systolic wave, and the diastolic wave is becoming more prominent than the systolic wave. Normally, systolic wave should be much prominent than the diastolic wave. So this is a useful investigation to assess the LV diastolic dysfunction. When you record the pulmonary venous flow, the cursor should be 0.5 to 1 centimeter inside the pulmonary vein. It should not be in the left atrium. It should be always inside the pulmonary vein, from where you will be recording the pulmonary venous flow pattern. Diagnosis.
HCM.
HCM, very good. Why did you say that?
So there is same which is occurring.
Yes, there is
Systolic anterior motion of
systolic anterior motion of the anterior mitral leaflet, yes. And also thickening of the gross thickening of the
posterior wall.
yeah, endoventricular septum is significantly thickened. So both put together, you can make a diagnosis of hypertrophic cardiomyopathy. Very good, excellent. SAM of IML, IVS hypertrophic cardiomyopathy. Okay.
RA thrombus, RA mass.
Yes, you discuss RA mass. Don't commit as a thrombus. This actually turned out to be a right atrial lipoma. So lipoma is the second commonest tumor in the right atrium. So this was a case of lipoma in the right atrium, which actually completely fills the right atrium. So lipoma. Look at carefully. What do you find here?
ASD.
ASD,
There's a good there's a large ASD, very good.
Related to
RV.
RV.
Is there a displacement?
Yes, tricuspid valve is
tricuspid
displaced.
Yes, tricuspid valve is displaced. And if it is tricuspid valve, what is this chamber?
Morphological left ventricle.
And there's a tricuspid valve which moves with what? With the
The RV, it's the atrialized RV.
yeah, there. So this is a posteriorly placed RV. This is the LV. This is a posterior placed RV. And what do you find here? There is a mitral or a LV associated atrioventricular valve regurgitation. So when you look at the whole thing, the RV is posterior, LV is anterior, the tricuspid valve is displaced downwards. There is significant tricuspid regurgitation. There is an ASD. And what is your full diagnosis?
Epstein's,
Yes, very, very good. There is an Epstein's anomaly. Yes.
Epstein's in the
with
Epstein's
CCTV.
Agree with you. There is an Epstein's anomaly. Yes. What else?
LTGA with Epstein's.
LTGA, very good. LTGA, very good. Left atrioventricular valve mitral, left atrioventricular valve regurgitation as a part of the Epstein's anomaly and an atrial septal defect. So patient is having L transposition. Patient is having Epstein's anomaly like Epstein's anomaly like an involvement of the left atrioventricular valve, giving rise to left atrioventricular valve regurgitation, atrial septal defect. So that is so you can put it as L transposition Epstein's anomaly ASD. So that will be easier. Associated with left atrioventricular valve regurgitation. Okay, I think that's the end of it. We've shown you some about 30 echo clippings of the various types, starting from tumors. M-mode also we have shown, aortic dissection, or submitral aneurysm. Most of the things you could diagnose. I think your understanding of the echo is very good. Next class, what you would like to? We'll have a case discussion.
Okay.
Okay. Then next week we'll have a case discussion. And any doubts about the echo that we have discussed today? If you have got any doubt, you can ask now. Otherwise, we'll stop it.
sir, please explain that once that pulmonary blood flow echo,
Pulmonary blood flow.
that S wave, D wave, and
Oh, pulmonary venous flow.
pulmonary vena.
Normally, what is the pattern of pulmonary venous flow? There is a prominent S wave during systolic phase and a less prominent diastolic wave and a normal or a small air reversal. Why the S wave is more prominent than the D wave? It is during systole that the atrium fills more. Why? After the atrial contraction, what happens to the left atrium? After the contraction, it relaxes or dilates. When it relaxes or dilates, immediately there is a reduction in the left atrial pressure and the blood from the pulmonary veins are sucked into the left atrium. And during the late phase of systole, what happens?
What's the during?
During the late phase of systole, what happens to the mitral valve?
Atria contract.
No. Late part of the ventricular systole. What will happen to the mitral valve? What happens to tricuspid valve? What is the mechanism of X-dash wave? X-dash wave.
Not getting.
Bulge of the AV valve into the left atrium.
Yes, it is pulled. The AV valve is pulled down into the corresponding ventricle, left ventricle or right ventricle. So similarly, in the pulmonary blood flow also, initially there is a large volume of blood coming from the pulmonary veins into the left atrium during the systole because of the left atrial dilatation or the left atrial relaxation after the contraction. And this is followed by pulling down of the tricuspid, the mitral valve into the left ventricle during the late phase of the systole. That will result in a sudden increase in the left atrial volume, and left atrial pressure falls again. And because of this, there's a large volume of blood flowing from the pulmonary veins into the left atrium, and that will give rise to a prominent S wave. During diastole, what happens during diastole? The mitral valve is open, and the left atrial flow is mostly left atrium behaves more like a conduit, and the wave which is generated by flow through the left atrium is much less prominent than the S wave. This is known as the D wave, and S wave is less prominent. What happens to the AR, air reversal? Air reversal means that during the atrial contraction, the blood is drained into the left ventricle mostly, but some part of the blood can be regurgitated into the pulmonary veins. So that is what is meant by air reversal. When a patient has got resistance to flow of blood from the left atrium to the left ventricle, that will result in more of reversal of the air wave. Flow reversal occurs more prominently in these patients, and that will give rise to a more prominent air reversal. The abnormalities of the air reversal can be detected by two measurements. One by looking at the velocity of flow reversal, and if the velocity of flow reversal is more than 35 centimeters per second, that is abnormal. You look at the duration of the air reversal, and from the air reversal duration, reduce the mitral air wave duration. And if you look at here, in this patient with pulmonary venous, air duration is 177 millimeters, and while the mitral air duration is 118 milliseconds. So if you reduce 118 from 177, this patient is having a difference of around 60 milliseconds. Any air reversal minus A wave more than 30 milliseconds is abnormal. So because of this, by another important problem that can happen associated with the LV diastole dysfunction, the pattern of the flow pattern into the left atrium can change, and that can result in less of flow during systole and more of flow during diastole. So less of flow during systole, more flow during diastole. The air reversal having a longer duration and greater velocity all indicate significant LV diastole dysfunction. And in these patients, the mean LV diastolic pressure, or you don't use the word mean, the LV diastolic pressure can be more than 15 millimeters of mercury. Is it clear to you?
Yes, sir. Yes, sir.
Any other doubt? So if you look at the pulmonary venous flow in this patient, this is the A wave, which is definitely shorter than the D wave. So indicating there's some degree of RV dysfunction, LV diastole dysfunction, and also the air reversal is much longer duration. Velocity is around 35 centimeters per second. All put together, there is evidence to believe that the patient is having significant LV diastole dysfunction and indicate an LV filling pressure of more than 15 millimeters of mercury.
Okay.
Okay, any other doubt?
No.
Okay, so I think we'll stop at this level. Next week we'll have a case discussion. One of you can come ready for discussion, and so that we can have a very good case discussion. Okay, thank you. Good night.
Good night.
Good night.
Thank you so
So,
much.
sir, with your permission, shall I close this meeting?
Yes.
Yeah, thank you very much, sir. So from here, I'm ending this meeting. Thank you. Thank you,
Thank you.
Rajesh. Good night.